This PowerPoint is on sleep disturbances in the older adult. This is a geriatric syndrome case study by Ashley Sumner. Sleep disturbances in the older adult include four main topics. The first one is advanced sleep phase syndrome, or circadian rhythm sleep disorder. Patients who are newly retired maybe go to bed early, wake up early, require a nap during the day, which is sort of frustrating for them because they do have less to do during the day. They complain of poor sleep, but they don't actually realize that they're getting adequate sleep. They just feel because they're more tired during the day that this is a poor quality of sleep. Another type of sleep disturbance is sleep disordered breathing, or obstructive sleep apnea is one of those. The rates go from 38% to more than 60% in the elderly, and don't usually include obesity as a risk factor for that. There's also insomnia. This is described as a persistent difficulty initiating or maintaining sleep that results in general sleep dissatisfaction. Also, the last one, sleep-related movement disorders. This includes restless leg syndrome, periodic limb movement disorder, rapid eye movement sleep behavior disorder. The background and significance for us as NPs is more than one half of elderly patients report sleep complaints. Some are physiologic, and others are associated with primary or secondary sleep disorders. Also, aging is associated with a decrease in the quality of nighttime sleep, and 30% of aged persons may experience chronic insomnia. As nurse practitioners, advanced sleep phase syndrome is characterized by routine and involuntary sleep and wake times that are several hours earlier than societal norms. We need to, as nurse practitioners, be able to educate the patients that this is normal, and also be empathetic to them, that it is pretty easy to adjust their bedtimes to go to bed later and actually wake up later in the morning so they don't feel as if they're more tired during the day. But it is said that a nap during the day can actually make them feel better and make their sleep at nighttime more restful. And then another thing, it's critical that sleep problems are not mistaken for physiologic changes in sleep-wake patterns and sleep architecture that occur throughout the lifespan. So we need to be diligent in making sure that these patients are not just diagnosed maybe with insomnia, and perhaps it could be increased anxiety or maybe a new onset depression that's actually causing this sleep disturbance in our patient. The patient I chose for this project was actually a guy that just came in for medication refill and a follow-up on his high blood pressure, but once we delved more into his medications and kind of his lifestyle, he was definitely a sleep disturbance patient. He presented with no known allergies. His medicines were amlodipine, 5 milligrams PO once daily. He also was on a nasal spray, 2 sprays each nostril at bedtime, Claritin 10 milligrams PO once daily at bedtime. He also took did clotrimazole, just an external cream, apply a thin coat over his eczema flares. Lipitor was 40 milligrams PO daily. Meloxicam 7.5 milligrams PO daily with food. He was also on ropinirole, and that was for his restless legs. He was taking 1 to 2 tablets at bedtime, depending on how he felt that day. And then his Zolpidem or Ambien 10 milligrams PO every night at bedtime. This patient was actually a very healthy guy. He was 76 years old. He had the chickenpox when he was in elementary school, minimal scarring. He was up to date on his pneumococcal pneumonia, his shingles, and his influenza shots. He got his flu shot in October of this year. He had his colonoscopy in 2017, and his chest x-ray, EKG, UA, and all his lab work recommended for the Medicare wellness screening was done in April of this year, so he's up to date on all of that. He did have a pertinent history of primary hypertension, insomnia. He had some eczema, and we later found out that that was probably from his Zolpidem and ropinirole. It's pretty common. He had restless leg syndrome and then peripheral neuropathy, probably from his high blood pressure. He came in with complaints of mild paresthesia to his hands and feet, and he also had some mild anxiety. Most of his review of symptoms was negative. He didn't have any chest pain, dyspnea, increased daytime sleepiness, dizziness, or recent falls. He really wasn't positive for anything, just kind of reported some anxiety, but not any more than he was used to. And then his paresthesia in his hands and feet were that way all the time, so he didn't really even take anything for that. So, like I said, he was a pretty healthy, active guy. His vital signs were as follows. His blood pressure was 136/86, which was normal for him. That was in his right upper extremity. He was sitting down. His heart rate was 70, temp 98.4 orally. His O2 sat was 98% on room air. He's 5'11" and weighed 185 pounds. His BMI was calculated at 25.8, so that's normal for his body weight. Findings, he was negative for signs of fatigue, dementia, disheveled clothing, or any inappropriate affect. He was really pleasant, very appropriate. His PHQ-9 score was 0. He didn't report any signs of depression or symptoms or anything like that. His GAD-7 anxiety score was 2. He reported no increased anxiety. His home safety assessment checklist indicated an extremely safe home. He had smoke detectors, no loose rugs. It was very well lit, and he did have his wife there with him to help if he needed anything. I did say that he may need a sleep study if insomnia symptoms were increased while on the zolpidem, or if he had any increased daytime sleepiness. Maybe a sleep study would be good for that, since he's been on his medicines for more than 10 years, which I'll get to later in the slides. And then I didn't order any labs for this patient. Plan for this patient. He should continue taking his zolpidem as prescribed for his insomnia. He should also continue to take his ropinirole as prescribed for restless legs. And I did find that although these medications can have an increased risk of falls for the elderly, this patient's been on both meds for more than 10 years. The pros and cons should always be weighed with the patient and with your supervising physician, and the patient should be educated on the risk of falls and some increased confusion during the night with both of these medications. If I was prescribing this medication, I would probably prescribe one of these two, not both, just due to the risk if this was a patient I was putting on newly for sleep disturbances. An article discussing zolpidem states that this class of medication has been included in the Beers criteria of potentially inappropriate medications for use in older adults. So I did find this pretty pertinent information for my future prescribing. Differential diagnosis for this could be obstructive sleep apnea ruled out with a sleep study. That's how you would know if it was obstructive sleep apnea versus insomnia. And it could also be increased anxiety, but that was ruled out with a GAD-7 score of 2. And then maybe it could also be a new onset depression for a patient, but that was ruled out with this patient by his PHQ-9 score of 0. So my final diagnosis was insomnia due to generalized anxiety disorder and circadian rhythm sleep disturbances related to recent retirement. Community resources needed. I feel like this patient would benefit if we could encourage them to engage in activities at a local community center. That would foster some increased activity during the daytime, and maybe then he wouldn't notice that he was more tired during the day, or when he did lay down for his nap, he would get a more restful nap, and then in turn be able to stay up later at night and be able to have a more restful sleep during the nighttime and maybe sleep a little bit later in the daytime. And again, that would kind of get his mind off of daytime sleepiness and any feeling that he wasn't getting adequate sleep. As we know, there's always things that can affect a diagnosis and plan of care negatively. Some of these would include the patient may resist going to the community center, maybe they're socially uncomfortable, or they are just content sitting at home and doing the same thing every day. This could hinder their activity level and maybe make them focus more on that they're tired and not getting adequate sleep. Also, our patient could take too much of their zolpidem, and that would be a fall risk for them, or even a respiratory depression risk if they were to take too much. Maybe they forgot if they took their medicine and then they take another dose 30 minutes later. So this could be risk factors for these patients. They could also, in today's world, of course, sell zolpidem to meet financial needs if they're retired and maybe they didn't have as much money as they thought they would. Maybe they're selling their zolpidem just to kind of meet financial needs. Also, they could be dishonest in their anxiety and depression screenings in fear of judgment or labeling of some sort. Maybe they don't want anxiety or depression as a diagnosis for them, just out of pride. As we know, a lot of our older adults are prideful. The patient could also have an underlying condition causing symptoms, so we as NPs need to be really adamant in researching their diagnosis and making sure the signs and symptoms fit the diagnosis that we're giving them, so we don't misdiagnose our patients or, like I said, overlook something that could be contributing to their insomnia. In conclusion, we as NPs need to be extremely diligent in our assessment skills, our history-taking skills, and up to date with current research recommendations in order to adequately treat our older adults dealing with sleep disturbances. This was a fairly simple topic, I guess you could say, but we do need to be very mindful of if we are diagnosing these patients correctly with, say, insomnia or restless leg, and we need to be making sure there's not something more going on where we can't see. So we need to be, up to date with their blood work and up to date with their EKG and up to date with their chest X-rays, just so we know there's nothing going on, cardiac-wise or maybe even neuro-wise. We just need to be very diligent with these assessment skills and with our intuitiveness to these patients. We also need to do adequate medication research, make sure that we are up to date on all of the latest medication interactions, all the risk factors for the elderly, what maybe could be metabolized differently in our older folks. So we just really need to be diligent with this population and the topic of sleep disturbance. References for this presentation are listed here. I want to say thank you for listening to my presentation. References for this presentation are listed here. I want to say thank you for listening to my presentation, and I hope